Assalamu alaikum. Today I'm going to discuss kidney trauma, which is an important topic in urology or renal surgery. So I'm going to introduce this topic. We all know that kidney is one of the retroperitoneal structures. It is fixed by vascular pedicels in its place, and it is protected by surrounding perinephric fat, posterior abdominal wall muscles, and rib cage. And it is a part of polytrauma in 5% of the cases, meaning that it is not usually involved in kidney trauma. It is polytrauma. It is rarely involved in polytrauma, in severe types of polytrauma. Mechanism of kidney trauma. So we see that penetrating or blunt trauma usually causes kidney trauma, but blunt trauma is more common. And kidney trauma is seen in head-on collisions in road traffic accidents and fall from height and contact sports. Sudden rapid deceleration can cause avulsion injury at the pelvic ureteric junction or renal pedicel. Penetrating injuries are rarely involved, and when they occur, they can cause direct tissue disruption and are associated with adjacent organ tissues injuries. Now we will discuss the presentation next. So it presents as loss of consciousness, hemodynamic shock because of associated injuries. The patient can go in hypovolemic shock because of excessive bleeding. And hematuria is a common presentation, which is pathognomonic of renal trauma. And its absence does not exclude renal trauma, meaning that if renal trauma has occurred, it is not necessary that hematuria may be present. The severity of trauma does not correlate with hematuria. Hematuria does not tell us about the severity of trauma, but it can be presented. So trauma causing lower rib fractures with or without vertebral injury fractures should raise the suspicion about the underlying renal injury and should be further evaluated. If there is a rib fracture or a vertebral fracture, so there should be suspicion of renal trauma. Now we will discuss the management of renal trauma. Contrast enhancement CT scan is usually done, which is necessary to delineate the type of renal injury. It provides information about the presence of parenchymal laceration, its depth, extension into the pelvic calcaneal system, and the extent of urinary extravasation. Urinary extravasation is the amount of urine that leaks when the kidney is injured. Provides information about other abdominal injuries and status of contralateral kidney injury. When nephrectomy has to be done, we should know the status of the opposite kidney as well, whether it is functioning or not, or whether nephrectomy should be done or not, because kidneys has an important role in the excretory function of the body. So its function must be preserved, and we have to make sure that the opposite kidney is healthy when we have to do nephrectomy. So contrast enhanced CT scan tells us about the renal injuries classification that I will discuss in the next part. So indications for contrast enhancement CT scan in abdominal trauma include when there is abdominal trauma with gross hematuria, microscopic hematuria with hypotension, which is when the systolic pressure is less than 90 millimeters mercury, rapid deceleration injury, children with microscopic hematuria with less than 5 RBCs count, and all penetrating renal injuries give the indication for contrast enhancement CT scan in abdominal trauma. So the indications for emergency surgical exploration. Surgical exploration or laparotomy is done when there is an expanding or pulsatile retroperitoneal hematoma, pelvic ureteric junction avulsion, renal pedicel injury, and hemodynamic instability, or in cases of shock. A surgical laparotomy must be done in the following 4 conditions. Now we will discuss conservative management with close surveillance. It is done because it is sufficient in majority of cases of isolated renal trauma. When there is a single renal, only the kidney is injured, we prefer conservative management. So when there are low-grade injuries, I will discuss the classification later. So low-grade injuries or even in grade 4 injuries are managed conservatively with bed rest, antibiotics, and in case of penetrating injuries, and serial HB estimation must be done. Re-imaging can be done after 2 to 4 days in case of falling HB levels. When there is anemia, And when there is fever, re-imaging must be done 2 to 4 days later. And when there is an expanding flank mass, when a palpable flank mass is there, re-imaging must be done. Persistent urinary leak can be managed with internal DG stent or PCN, percutaneous nephrostomy is done. If there is urinary leakage, percutaneous nephrostomy is done or a DG stent is inserted. Okay, so I'm going to discuss renal trauma from the book now. So it says that 10% of cases of abdominal trauma usually involve kidneys. 90% injuries occur due to blunt trauma and 10% due to penetrating trauma. Blunt trauma is seen in road traffic accidents or falls, and penetrating trauma is seen in gunshot or stab wounds. 95% of blunt trauma can be managed conservatively. I've discussed conservative management in the previous part, while majority of penetrating trauma requires surgical exploration and repair. So I'm going to discuss the staging of renal trauma now, which is very important. So we have 5 grades basically. Grade 1 is when there is contusion on the kidney. And one more important thing, this is done on CT scan. The staging of renal trauma is done on CT scan imaging. So grade 1 is contusion or no laceration. There is only bruising seen on the kidney. Then there is grade 2, laceration is less than 1 centimeters. Grade 3, laceration is more than 1 centimeter. Grade 4, injury is involving the collecting system, the papillae, calyces, and renal pelvis. Then grade 4, the kidney is shattered and there is hilum avulsion, and excessive hemorrhage is seen in grade 4. I'm going to discuss the grades via diagram. So grade 1, we see that there is a subcapsular hematoma. There's only bruising. The blood is not leaking from the kidney. Then there is grade 2. Like I mentioned before, the laceration is less than 1 centimeter, and there can be a hematoma formation in the subcapsular region and in the perinephric fat surrounding the kidney. Then there is grade 3. The laceration is more than 1 centimeter in size and there is excessive bleeding. A larger hematoma is formed. Then moving to grade 4, we see that there is injury in the collecting system of the kidney and there is excessive bleeding. Renal artery or vein are involved. Arterial blood clots may form in the endothelial region of the arteries. And then there is grade 5. Grade 5 means that the whole kidney has ruptured and there is severe bleeding. The patient may go into shock. The kidney has shattered and there is avulsion of the renal hilum where the blood vessels enter the kidney. So now we are going to discuss the management. So first we will discuss the management in a hemodynamically stable patient. So we have to do renal imaging in such patients with contrast, enhanced CT scan of the abdomen or IVU, intravenous urography. And if CT scan is not available, IVU is done. So this looks for renal injury and its severity, injury to other abdominal organs, or in the intactness of the other kidney. Surgical exploration is undertaken if there is persistent gross hematuria or expanding or pulsatile retroperitoneal hematoma. So we are going to discuss the hemodynamically unstable patient next. So the hemodynamically unstable patient must be rushed to the operation theater to control the bleeding. Partial or total nephrectomy may be required to control the bleeding. An on-table IVU may be performed to confirm the renal injury and look for functional status of the other kidney. Associated injuries should also be dealt accordingly. So the hemodynamically unstable patient is not investigated first. He or she must be rushed to the operation theater first to do important measures to prevent the patient from going towards shock. Okay, coming to the clinical features, there is a history of blunt or penetrating trauma to the flank region. Hematuria is one of the hallmarks of renal injuries. It may be microscopic or macroscopic. There is flank pain and bruising. Investigations include ultrasonography. It helps demonstrate the subcapsular or retroperitoneal hematoma. Contrast enhanced helical CT scan. CT scan of the abdomen is the best imaging modality for the assessment of renal injuries and for grading of renal trauma, like I've discussed before. But the patient must be hemodynamically stable. Okay, one-shot IVU. This is done in cases of emergency exploration, laparotomy, or in unstable bleeding patients. Since a nephrectomy may be necessary, it is necessary to investigate the real functions of the contralateral kidney before exploration. 2 milliliters per kg of urograph in contrast is injected intravenously, and a single film X-ray KUB is taken after 10 minutes. So now we are going to discuss the conservative management. All patients of renal injury suspicion should be admitted to the hospital. Over 90% of the renal injuries are minor and can be managed conservatively. So conservative management includes admission to the ward, bed rest, recording vitals frequently, analgesics and IV fluids, and cross-match blood and transfusion if necessary. If there is excessive blood bleeding, the patient must have cross-match blood so that blood can be transfused into the patient. So what are the indications of surgery when there is severe bleeding and shock, there is an expanding or pulsatile retroperitoneal hematoma, associated injuries to the other abdominal organs such as bowel, liver, spleen, and pancreas? So, surgical management, a midline laparotomy is usually done to explore the both kidneys and other viscera for concomitant injury. Bowel, liver, and spleen and pancreas are examined. One shot IVU for the other kidney to check for its function, and exploring the expanding or pulsatile hematoma, repairing the renal injury. Nephrectomy is done if there is severe injury, severe bleeding, or life threatening hemorrhage, and the other kidney must be healthy so that nephrectomy is done easily. Surgical options include small tear or lacerations, must be sutured. Partial or complete nephrectomy may be done in cases of grade 2 and grade 4, I've discussed before, when there is complete uh, avulsion of the kidney has been ruptured and the hilum has been avulsed and the collecting system has been damaged, and nephrectomy may be done, and a damaged solitary kidney must be repaired. In cases of grade 1 or 2, when the injury is not severe, the damaged kidney is repaired and a nephrectomy is not indicated in such cases. Thank you very much.